Thanks a lot for this kind invitation. It is a great pleasure to be here with friends and also to participate in this fantastic meeting. And I will encourage my working group to organize something similar in Greece. I think that, as Professor Delgado said previously, there is no change in the treatment of acute heart failure in the last 20 years. The only addition was the use of Levosimendan as inotropic therapy and Neseritide as vasodilator therapy. We have the three classes of drugs for the improvement or the symptomatic improvement of patients, and also there is no class 1 drug in acute heart failure except diuretics. But all this is based on experience and on randomized trials. And the current indications for the use of inotropes is to use these drugs in patients with low output syndromes in order to protect peripheral organ from hypoperfusion and to restore hemodynamics. And the class of recommendations in European Society of Cardiology is 2A, level of evidence B, while in recent American Heart Association guidelines there is a downgrade of inotropes as 2B in hospitalized patients with symptoms of worsening of heart failure. There are now prospective trials comparing the three classes of drugs, but now we have some data from using propensity match scores from large registry concerning real-world patients. And you can see in this alarm sub-analysis performed by our group at Alex Mebaza that inotropes can increase in hospital mortality in comparison to diuretics that have an intermediate effect on mortality, and the most beneficial drugs are vasodilators. That this is not compatible with guidelines because diuretics are class 1 while vasodilators are class 2A. In this sub-analysis, in inotropic arm excluded patients on Levosimendan, it included only patients on classical inotropes like Dobutamine, dopamine, and catecholamines. And a rational use for these drugs for inotropes is to evaluate the patients clinically initially, to evaluate the systolic blood pressure and the signs and symptoms of hypoperfusion and congestion, and to give the drugs especially in patients with systolic blood pressure between 85 and 100, and in some cases in patients with systolic blood pressure over 100, but lower than 120. This is a choice as a first line of inotropes. We have another choice also for patients with hypoperfusion and low systolic blood pressure, but in these patients the recommendation is a second line treatment in order to wean these patients from mechanical support or from vasopressors that are used widely for the restoration of systolic blood pressure. This is the current indications. Levosimendan is the new drug, is the new inodilator used in clinical practice. I will describe briefly some mechanistic initial studies. First of all, Levosimendan has a triple mechanism of action. Stabilizes troponin C, increases contractility without increases in intracellular calcium. The second mechanism is to activate ATP potassium-sensitive channel in peripheral vessels, causing vasodilation, and also stimulating mitochondrial ATP-sensitive potassium channel can create cardioprotective effect, acting as a scavenger of free radicals, as a scavenger of oxidative stress in these patients. This explains the protective effects, especially in ischemic patients, in the presence of stunning myocardium after interventions in acute coronary syndromes. The first trials compared the effect of Levosimendan with Dobutamine on myocardial oxygen consumption. You can see that Levosimendan has a mild effect on myocardial oxygen consumption in comparison to Dobutamine that has harmful effects on myocardial oxygen consumption. It is very important to see also another mechanism of action for the Levosimendan. At higher doses or giving bolus dosing can activate the phosphodiesterase inhibition mechanism of this drug. Looking at the action of levosimendan, you can see that at higher doses the drug acts as phosphodiesterase inhibitor 3 that may explain the hypotensive effects, also arrhythmogenic effects at the higher doses of giving bolus dosing in large clinical trials. But I think that giving the drug at lower doses, this drug is safe in order to produce arrhythmias. In this trial, you can see also that levosimendan reduces inflammatory cytokines in circulation of patients with acutely decompensated chronic heart failure in comparison to placebo or dobutamine. It also reduces pro-apoptotic factors through potential the activation of mitochondrial potassium-sensitive channels. And this is also another study looking at the oxidative stress. Levosimendan keeps stable the levels of oxidative stress in comparison to placebo that increases in these patients the oxidative stress, and this is potential a mechanism that deteriorates the cardiac function during the destabilization of these patients. And we have also data about the effect of levosimendan on right ventricle in patients with biventricular heart failure, performing the new echo imaging techniques like TDI. You can see that levosimendan improves not only the systolic function of right ventricle, but also the diastolic function of right ventricle in comparison to placebo. And this is related also with the reduction of BNP and reduction of inflammatory cytokines in this trial. There are small also trials that compare the role of the effect of levosimendan versus dobutamine or placebo on renal function. This is a trial comparing the effects of levosimendan versus dobutamine on GFR. You can see that levosimendan preserves renal function in these patients permanently during the destabilization in comparison to dobutamine. And this is a very recent paper published in European Journal of Heart Failure by Fendele. The administration of levosimendan compared with administration of placebo, there is not only increase of diuresis and also of reduction, improving of GFR in this patient in levosimendan arm, but Fendele also investigated the effect of renal blood flow using non-invasive techniques and demonstrated there is increase in renal blood flow in this patient due to peripheral vasodilatory effects on renal artery. Thus, it means that patients with acute cardiorenal syndrome potentially has more benefit from levosimendan treatment in comparison to other inotropes. And finally, there is this hemodynamic study from LA looking at the coronary blood flow in patients with ischemic heart failure. And you can see that the administration of levosimendan increases coronary blood flow, and this is in keeping with our data with ECHO, estimating the CFR, coronary flow reserve in these patients. As you can see that levosimendan improves 48 hours after the infusion of the drug, statistically significant, the coronary flow reserve in these patients. And this is related with a reduction of diastolic pressure, estimated by E/E ratio, and also the BNP reduction. We know that the CFR is also impaired in patients with chronic heart failure during the acute decompensation because of elevated work stress, and this is potential explanation for the use of levosimendan in these patients. And the Kleber's group showed also that the administration of levosimendan during PCI in patients with LV dysfunction and coronary syndrome improves hypokinetic segments after the infusion of the drug. This is first evidence that the drug has anti-stunning effects in these patients, and this is in keeping with another study looking at the cardiac index at CFR also after PCI with the use of levosimendan. That means that potentially the drugs exert preconditioning effects in ischemic patients with chronic heart failure, that it is another target group for the use of drugs. And now we have a meta-analysis for the use of drugs in cardiac surgery patients. You can see that the preparation of these patients of cardiac surgery with levosimendan reduces the release of troponin after the cardiac surgery. This is also an evidence that the drug reduces ischemia reperfusion injury in these patients and protects heart from the harmful effects of reperfusion. What about the clinical trials? The first trial was the LIDO trial. The LIDO trial was a hemodynamic study evaluating the increasing cardiac output and decreasing waist pressure in these patients in comparison to dobutamine. The Levosimendan achieved the primary endpoint. There was greater improvement of hemodynamics in these patients in comparison to dobutamine, but also LIDO showed that another thing, that in this trial the Levosimendan was safe drug. Why? Because this trial was a hemodynamic study, because many patients with hypovolemia excluded during the hemodynamic control from the use of Levosimendan and avoided the hypotensive effects, sympathetic activation after the hypotension, and also the arrhythmogenic effect. And also, LIDO trial demonstrated that patients on beta blocker treatment is a target group for the Levosimendan, because it had greater benefit on hemodynamics with Levosimendan in comparison to dobutamine. The next trial was the survival trial. This trial was not a hemodynamic study, was a study that investigated all-cause mortality at 6 months in these patients. The primary endpoint was all-cause mortality. The trial failed to show benefit with Levosimendan on primary endpoint, but also looking at the sub-analysis, subgroups of this trial, you can see that patients on beta blocker had benefit in favoring Levosimendan for in-hospital mortality, statistically significant in comparison to patients without beta blocker use at admission. This also means that the beta blocker, patients on beta blocker is the proper population for the treatment with Levosimendan in acutely decompensated heart failure patients, and also Levosimendan reduces more effectively the BNP than dobutamine in this patients. A special group also, sub-analyzing by Alex Mebaza at our group, was patients with liver congestion. We know now the evidence for high cardiohepatic syndrome of heart failure. It concerns about 30% of these patients. It created also by congestion and elevated CVP, but also from hypoperfusion. This is similar to wet and cold patients. And this group of patients had also benefit from Levosimendan treatment. This is also sub-analysis published in European Heart Journal and also presented in the previous European Society Congress. You can see that there is reduction more effectively with Levosimendan in liver enzymes, abnormal liver enzymes, in the arm of Levosimendan in comparison to dobutamine. The last trial was the REVIVE trial, the REVIVE-2 trial. The REVIVE-2 trial was a trial of 2006, but published just 1 year before in JACC heart failure. But the REVIVE has as a primary endpoint the symptoms of the patients, the global status patient assessment, a composite endpoint of dyspnea scores and also well-being of the patients. And you can see that the primary endpoint was positive for Levosimendan, because Levosimendan had greater effect on improvement of symptoms. But the trial disappointed for the secondary endpoint, because there was a numerical increase of deaths in the arm of Levosimendan at 30 days and also 60 days, not statistically significant, but it was the first evidence that potentially the drug increases mortality in these patients. But there is explanation for this. And the explanation is that looking at the hypotensive episodes, you can see here that in Levosimendan group there was a hypotension in 50% of patients. But it is interesting to see the placebo group. Looking at the placebo, you can see that 36% in placebo group has also hypotension. That means that Levosimendan in this trial was rescue therapy on the top of other vasodilators like milrinone and like nitrates and also dobutamine. It means that to use a drug alone, not to combine with other drugs, because there is a high risk to create hypotension and also arrhythmias. And this is also propensity match score analysis from especially for Levosimendan from alarm registry. And you can see for especially more specific for Levosimendan in patients with acute decompensated heart failure, performing propensity match scores that counteract the severity of the disease in these patients and other cofactors, that there was lower mortality with levosimendan in acutely decompensated patients in comparison to dobutamine. And this concerns real-world patients, not patients included in clinical trials. But the current recommendation of European societies for dobutamine 2A is preferable agent due to lower cost after the SURVIVE trial. For phosphodiesterase inhibitors, there is a 2B evidence, also with dopamine after the disappointing results of Rose trial and also DAD2 heart failure trials. And for levosimendan is 2B, but is preferable agent for patients on beta blocker in the European Society guidelines told. And in the final part of my presentation, I will speak about the advanced heart failure patients to give levosimendan in pulsed in repeated infusions. That is also a very interesting approach to treat these patients. This based on the duration of hemodynamic action due to active metabolite. You can see that there is sustained effect of the drug which is compatible with increase of active metabolite, keeping the effects of the drugs at least 7-10 days after the initial infusion. And this was a nice rationale to create trials on pulsed infusion. This was the first trial by our group. This was mechanistic trial, found that patients on 6 infusions every 1 month at 0.1 without bolus at 24-hour infusion, this regimen can improve the LV function in these patients to reduce BNP levels and also inflammatory cytokines. But I think that it is very important before to start this regimen in these patients to estimate the contractile reserve of these patients. If there is contractile reserve, this is the most proper group for the use of these regimens prospectively in order to improve LV function. This is a trial that predicts the response of neurohormonal response and also clinical response in levosimendan treatment in pulsed infusions using echo stress dobutamine at baseline before to start the infusions of levosimendan. Thus, the existence of contractile reserve is very important for these patients. The next trial was a trial from John Nana's also group with advanced heart failure patients, 3 groups, 3 regimens, levosimendan, dobutamine, levosimendan plus dobutamine. This is also a regimen containing these 2 drugs, but is rescue therapy for very advanced heart failure patients, but increases the risk of arrhythmias, the combination of 2 drugs. But this trial, designed in this way, and you can see that levosimendan had more beneficial effects on mortality in these patients than the other 2 arms. And there is also a small study from Kleber's group with pulmonary hypertension use of repeated infusions in patients with vasoreactive pulmonary hypertension, giving pulsed infusions, and Franz Kleber's group showed that there is reduction in mean arterial pressure in these patients prospectively. And this was the rationale for the larger trial, the first pilot trial, Levo trial, designed by our group and also Austrian doctors, 13 centers in Europe, Austrian centers, Germany, centers from Germany and also from Greece, giving 6-hour infusion at outpatient basis at 0.2 and looking in advanced chronic heart failure patients with ejection fraction below 35 with a poor exercise and tolerance, and looking mainly at primary endpoint to improve quality of life and exercise tolerance in these patients, and as a secondary endpoint, event-free survival. And now we have the results. The paper is under publication in European Journal of Heart Failure, but presented in the previous heart failure meeting hotline session. You can see the primary endpoint was negative. There was no improvement of quality of life at 6-minute walking distance in these patients. There were some explanation about this, about the dosing, about the timing to estimate this primary endpoint after the infusions, but it was surprised that in secondary endpoint there was improvement of event-free survival in these patients long term. This is first pilot study. I think that now there are 3 ongoing larger trials, LION, LICA, and also ELEVATE, that will give the definite results about the role of pulse infusion in chronic heart failure. But looking at the recent meta-analysis included in a consensus report, in this consensus participated also doctors from Israel, Dr. Bengal, Dr. Yakosbili. This paper will be published in International Journal of Cardiology, including also a meta-analysis of pulsed infusion. You can see that this meta-analysis favoring Levosimendan in patients with advanced heart failure. Thus, in my summary, I think that traditional inotropes have several limitations in real clinical practice. Levosimendan seems to be superior than traditional inotropes in improving hemodynamics and neurohormonal response, but failed to improve prognosis in acute heart failure patients. But answering to the initial question, the revival of Levosimendan, I think that it's still good option for patients on beta blocker treatment, on patients with cardiorenal syndrome and worsening of renal function or liver congestion. And in the case of serial administration of Levosimendan, we have now preliminary results that may improve long-term outcomes in advanced heart failure patients, which is different population from acute heart failure. But we need more data on optimum time interval, a treatment duration, and more randomized trials are needed in order to evaluate the safety and efficacy of these strategies in the future. Thank you for your attention.
I have a question. This wonderful presentation. Please give us the key in what patient we must use Levosimendan. Which is the best patient, best feature?
The best patient is acutely decompensated, not acutely de novo, acute de novo, on beta blocker at admission with potentially underlying renal disease, and in patients with evidence of congestion.
And with low blood pressure?
At blood pressure between 90 and 120. The most ideal patients are patients with systolic blood pressure over 100, between 100 and 120.
Thank you very much.